Hello everyone and good afternoon. Welcome to the KIMS 1 session. Is everyone able to hear me and are the slides moving? One of you please confirm. Aruna?
Hello, ma'am. You're audible and visible, ma'am.
Okay, we'll go ahead with today's topic. Today we are covering the most important aspect in the preterms, which is the intraventricular hemorrhage, which results in the long-term morbidity, mortality, and sequelae. And also we will be covering the cranial ultrasound in neonates and the practical demonstration of the neurosonogram, which we do regularly in our NICU. So first let's discuss about the preterm IVH. The germinal matrix hemorrhage and associated intraventricular hemorrhage is the most common variety of intracranial hemorrhage in preterm neonates of less than 32 weeks of gestation. The incidence in preterm neonates is around 20 to 25%, and this incidence of IVH as well as severe IVH increases with each decreasing week of gestation in preterm neonates. The complications of the IVH are neonatal seizures, anemia, needing blood product transfusions, and as well as periventricular hemorrhagic infarction, post-hemorrhagic hydrocephalus, and in the long term, the sequelae like cerebral palsy, mental retardation, behavioral problems, and visual problems. So what is this germinal matrix? The germinal matrix is a highly gelatinous vascular structure, as you all can see here in this picture. It is located in between the caudate nucleus in the front and the thalamus behind, and you can see it in the sagittal view, which is like if you take the midline section of the baby's head, the sagittal view, in between the caudate and thalamus, there will be a notch-like structure which is called as caudothalamic groove. There the germinal matrix will be located. The germinal matrix is a highly vascular structure and it is highly angiogenic with high vascular endothelial growth factor levels. The vasculature of the germinal matrix are very fragile, and they have lack of vascular end feet and lack of pericytes, and the basal lamina are also sparsely distributed, thus making it a highly propensity for the bleeding in the germinal matrix in preterm babies. The germinal matrix also consists of neuroglial precursors that become the cerebral oligodendroglia and astrocytes and the late migrating GABAergic neurons in the future. And the germinal matrix starts to involute by 34 weeks of gestation and it completely disappears by 36 to 37 weeks of gestation. That is why we see this germinal matrix related bleeding in preterm neonates. So whenever there is any hypoxia or any insult to the baby at the time of delivery, then that leads to the increased production of vascular endothelial growth factor and angiopoietin 2, which leads to increased angiogenesis, because the babies also have the basal lamina, which is low in fibronectin, and paucity of pericytes in the germinal matrix, and less GFAP levels in the astrocyte end feet of the germinal matrix. These capillaries in the germinal matrix are highly fragile and are prone for bleed in that area. So coming to the blood supply of the germinal matrix, first let's see the arterial supply of the germinal matrix. Here the anteriorly you can see this is the Huberner's artery, which is a branch of the anterior cerebral artery, and these are the striate branches of the middle cerebral artery, and this is the anterior choroidal artery, which arises from the internal carotid artery, and from the top you can see the penetrating branches from the surface meningeal arteries. So these are all the three these types of arteries are supplying the germinal matrix. Coming to the venous drainage, Here we can see the medullary vein as well as choroidal vein and the thalamostriate vein. All these veins, they converge together at one point and they drain into the terminal vein. The terminal vein, if you can see, it's first draining in a vertical fashion and then it is taking a perpendicular direction and coursing along to the posterior side of the brain, where it ultimately drains into the internal cerebral vein and the vein of Galen. So in germinal matrix hemorrhage, in the severe grades of hemorrhage, there will be a periventricular hemorrhagic infarction. That is not in fact the continuation of this IVH. It is a separate entity which occurs due to venous congestion, which we will be seeing later. That is mainly because of this acute turn of direction of the venous supply, which leads to the venous congestion and development of subsequent infarction in the preterm babies. So now let's see the pathogenesis of IVH in preterm babies. It can be divided into three factors, which are intravascular factors, vascular factors, and extravascular factors. The intravascular factors, any disturbance in the blood flow to the brain, that is any hypotension and subsequent reperfusion injury causes bleed in the germinal matrix. That occurs because the preterms do not have the autoregulatory mechanisms to regulate the cerebral blood flow whenever there is an increase in the blood flow to the brain. So whenever there is a hypotension and we are giving a volume expansion, NS bolus or bicarbonate bolus, or whenever there is a hypercarbia which leads to increased cerebral blood flow, or decreased hematocrit, anemia also causes increased cerebral blood flow, as well as hypoglycemia. All these cause increase in the cerebral blood flow and increased propensity for the germinal matrix hemorrhage. As well as whenever the baby is agitated on a ventilatory support, there will be fluctuating cerebral blood flow, which can be seen in a ventilated preterm neonate. And whenever we are doing suction, whenever there is pneumothorax or increased PEEP, or whenever there is a PDA, there is a chance of increased cerebral blood flow leading to the germinal matrix hemorrhage. And also the venous anatomy, as I have previously mentioned, the change in the direction of the venous flow leads to the periventricular hemorrhagic infarction. Labor and vaginal delivery. So during the process of vaginal delivery, the baby's skull undergoes lot of is very compliant, and it overlaps the sutures and all, they will get overlapped, and this is also one of the factor for propensity to IVH, but even though it is not clinically proven in the studies. That leads to increased venous congestion during the time of the normal delivery. And respiratory disturbances, as we already mentioned, and systemic hypotension. Any platelet or coagulation disturbances also increases the tendency for hemorrhage in those tortuous capillaries. Coming to the vascular factors, the capillaries itself are tenuous and involuting, and they are in a remodeling state with high VEGF levels, with a large vascular and luminal area, and a deficient vascular lining predisposes them to hemorrhage. And they are lying at the vascular border zones, which predispose them to hypoxic ischemic injury. And extravascular factors are deficient vascular support and decreased fibrinolytic activity in the preterms also increases the tendency to the bleed. So how this bleeding in the germinal matrix can be minimized? We will see some preventive measures, like no routine suctioning for preterm babies, because suctioning and handling tends to increase the cerebral blood flow and increases the pressure. And optimizing the ventilation by using the volume targeted mode of ventilation, synchronized ventilation. Asynchrony leads to asynchrony, and pain, agitation also all lead to the increased cerebral blood flow. As well as treatment of the PDA with either indomethacin or ibuprofen or paracetamol, and fluid restriction, avoiding bicarbonate boluses, and slow infusion over an extended period all help in decreasing the optimizing the cerebral blood flow. As well as treating hypotension and maintaining the systemic blood pressure in an appropriate manner, treating the sepsis adequately, avoiding anemia by doing delayed cord clamping. All these factors help in decreasing the incidence of IVH. So the other risk factors are prematurity. IVH percentage decreases by 3.5% with each week of gestation in utero in the mother. So trying to avoid the prematurity itself decreases the incidence of IVH. And lack of antenatal corticosteroid therapy. As you all know, antenatal corticosteroids reduces the incidence of IVH by around 46%. And treating maternal infections, chorea amnionitis with appropriate IV antibiotics. Maternal hypertensive disorders also trigger the baby for IVH, and neonatal transport, particularly in the first 72 hours of life. So majority 90% of the intraventricular hemorrhages in the preterm infant occur in the first 72 hours of life. So avoiding the neonatal transport in the first 72 hours will help in reducing the incidence of IVH. In utero transport is the best form of transport. And CPR in the delivery room, increased intubation attempts, inadvertent tidal volume, that is high PIP and PEEP while resuscitating the baby, head low position, all these contribute. Hypotension requiring inotropic support, sepsis, thrombocytopenia, and disseminated intravascular coagulopathy contribute to the incidence of IVH. So this is about the preterm babies. Now coming to the term infants, even though it is the incidence of germinal matrix related IVH is less in term infants, it occurs most commonly in trauma during delivery, hypoxic ischemic encephalopathy or perinatal asphyxia, and any coagulation or platelet abnormalities, and the genetic mutations related to the same, hemophilia, therapeutic hypothermia during ECMO, and sinovenous thrombosis involving the thalamus leads to the germinal matrix bleed in the term infants. There are two most commonly and popularly used classification systems for the intraventricular hemorrhage. The classification of IVH is very important for deciding the next step of management and to explain about the long-term prognosis even to the parents. So while we are grading the IVH, there are two systems, papillary system and Volpe system. Whenever we are doing the neurosonogram to classify the IVH, first we should document the size of the ventricles and the bleed is present on which side, whether it is unilateral or bilateral, and the size of the bleed in relation to the size of the ventricles, and the ventricular indices measurement like ventricular index, anterior horn width, and thalamo-occipital distance, and the grade of the hemorrhage should be noted and should be documented in the file. So the neurosonogram or cranial ultrasound is as of now the best diagnostic modality to diagnose the intraventricular hemorrhage in preterm babies, and it can be easily done bedside in the NICU because the anterior fontanelle offers a good acoustic window in all babies. So first coming to the papillary system of classification, this was first introduced for CT scan and to classify the intraventricular hemorrhage into different grades. There are 4 grades in this. Then later on the Volpe classification also came into work. So the grade 1 germinal matrix is confined to the subependymal germinal matrix. Grade 2 is defined as the hemorrhage which is within the lateral ventricle, but the ventricles are normal in size. There is no ventricular dilatation. Grade 3 is the hemorrhage with distension and resulting in ventricular dilatation, that is the grade 3, and the hemorrhage will also be occupying more than 50% of the ventricle. The grade 4 is a parenchymal hemorrhage. Previously, they have mentioned it as a grade 4 as they thought it was a continuation of this, but now we will know in the next few slides that it is not a continuation of the intraventricular hemorrhage, but it is actually the venous congestion. So now it is being represented as periventricular hemorrhagic infarction rather than parenchymal extension. So this is about papillary classification. Next is Volpe's classification. In this, there are 3 grades are mentioned, with the 4th one being mentioned as intraparenchymal echogenicity. This is slightly different from the papillary classification. Here, we will give it as a percentage. The first grade 1 is blood confined to the germinal matrix region with minimal or no IVH. Less than 10%, it is extending into the ventricles. Grade 2 is IV. 10 to 50% of the ventricular area is involved on the sagittal view. Grade 3 is more than 50% of the ventricular area is involved when you see in the sagittal view along with the distension. Grade 4 is intraparenchymal echogenicity, and that echogenicity is of greater intensity than the choroid plexus. We will be seeing the choroid plexus when we go to the cranial ultrasound presentation. So the echogenicity will be of greater intensity than the choroid plexus and is located in the periventricular white matter, and it is observed in both the coronal and the sagittal views concomitantly with the IVH. So it will be associated with IVH. Without the intraventricular hemorrhage, we will not be seeing the parenchymal bleed. So this is known as periventricular hemorrhagic infarction or venous infarction. So how does this, once the IVH develops, how does this present? It presents in 3 different ways. First is the catastrophic. Catastrophic means very acute deterioration. Saltatory presentation, which is a slow deterioration over a period of days. Catastrophic within a few hours. And clinically silent. The clinically silent variety is the most common type of variety, which is explained by unexplained fall in hematocrit or a failure of rise of hematocrit after giving a transfusion. Catastrophic presentation presents within a few hours, and the baby presents with stupor, respiratory depression or apnea, generalized tonic seizures, decerebrate posturing, and pupils not being reacting to light, quadriparesis, and the anterior fontanelle, if you observe, it will be bulging. Saltatory presentation presents with altered level of consciousness, hypotonia, decreased spontaneous and elicited movements, eye deviation, and altered respiratory pattern. So these are the 3 different clinical presentations of IVH. So what are the consequences of germinal matrix hemorrhage? So whenever there is a GMH related IVH, what we generally see, we see cerebral cortex as well as thalamic dysmaturation, as well as affecting the cerebral gray matter as well as the white matter, and cerebellar dysmaturation. Whenever there is a germinal matrix destruction, this leads to decreased proliferation of GABAergic neurons and decreased oligoprogenitor cells. So these leads to decreased mature oligodendroglial cells and cerebral as gray matter as well as white matter dysmaturation. And the hemosiderin, which gets deposited in the ventricles, causes the loss of external granular layer of the cerebellum, which leads to the cerebellar dysmaturation. So what are the complications of GMH IVH? The 2 major complications are periventricular hemorrhagic infarction and post-hemorrhagic ventricular dilatation. The risk of both these complications increases with the larger size of increased grade of the IVH. So let's see how to manage these conditions. The main thing will be the prevention. So once it has occurred, we should know how to manage the condition also. So PVHI occurs in a fan-shaped distribution in the frontal and the parietal lobes. We have seen previously the venous drainage. So if you see that it's a fan-shaped distribution of drainage, they all converge and drain into the terminal vein. So the hemorrhagic infarct will be in the fan-shaped distribution in the frontal and parietal areas. Later on, this infarct, when it gets absorbed, that becomes into a porencephalic cyst. So now we should know whether that cyst is either due to the PVHI or due to periventricular leukomalacia, which is another condition in the preterm babies. So how to differentiate it? In this, the circulatory disturbance in PVHI is venous, whereas in PVL it is arterial. So the ventricle will be grossly hemorrhagic. This is invariably seen in PVHI, whereas it is uncommon in PVL. And it is asymmetrical most of the time in PVHI, whereas in PVL usually the cystic changes are seen bilaterally. And during the evolution, the PVHI presents as a single large cyst, whereas PVL presents as multiple small cysts in the frontal and parietal areas. So it's a separate lesion from the IVH. How do we say it's a separate lesion? That is because when we do the Doppler ultrasound studies before the periventricular hemorrhagic infarction, you can see the decreased or absent flow in the terminal vein on the side of the large IVH. And also the ependymal lining of the vessels is intact most of the time. This suggests that this parenchymal bleed is a separate entity that occurs due to periventricular venous congestion followed by periventricular ischemia that leads to the infarction. that occurs because of the large IVH, which results in obstruction of the blood flow in the terminal vein. So coming to the next entity, that is post-hemorrhagic hydrocephalus. This is seen weeks after the onset of the GMH IVH. 25% of all the IVH progresses to established hydrocephalus. Then they need monitoring because not all the hydrocephalus needs treatment. Some will regress, some remain static. So this hydrocephalus is due to three mechanisms, that is impaired CSF absorption or obstruction of at the level of the aqueduct or the foramina of Leschka and Magendie by the particulate clots, as well as decreased plasminogen activities that is seen in preterm babies, and in the later point of time the inflammatory changes due to obliterative arachnoiditis. This results in impaired CSF absorption overall and distension of the lateral ventricles. So coming to the prognosis, the prognosis is mentioned in terms of the mortality rates and progressive ventricular dilatation in the survivors. So if you see the weights of the babies are divided into very small babies less than 750 grams and VLBW babies up to 1500 grams. So the mortality is as the grade of the IVH increases, the mortality increases up to 45% in extremely low birth weight babies, whereas it is half of that in babies with 750 to 1500 grams. Similar is the case with the hydrocephalus. In the very small babies, it increases up to 83%, whereas it is increases to 75 to 66% in the bigger babies. So how to manage the GMH IVH? So the main aspect is the prevention of the IVH, which we will see, and then initial or acute management to avoid the further damage by further bleeding and all. And the next one is treatment of post-hemorrhagic ventricular dilatation. So interventions in the antenatal period, the prevention of premature birth is the first and foremost intervention. This can be done by identification of the woman at high risk for premature delivery, treatment of infections, that is chorioamnitis and all, with IV antibiotics, comprehensive health care, giving importance to nutrition, and preventing the preterm birth by giving tocolytic agents, as well as 17-alpha hydroxyprogesterone begin at 16 to 20 weeks, prevents the preterm delivery compared to the placebo group. So prevention of preterm birth, when the preterm birth is inevitable, the mother has gone into spontaneous preterm labor, the first thing we should do is give the antenatal steroids, 2 doses, 24 hours apart of betamethasone, or 12 hours apart of dexamethasone, 4 doses, and then refer the mother in utero transport of the baby to a higher tertiary care center, because outbound babies and needing extensive resuscitation at birth and then transporting the baby in the first 72 hours of life has been shown to increase the incidence of IVH. So in utero transport to a tertiary care center, antenatal steroids, the second dose of steroid should be given 24 hours prior to the delivery for good effect for increasing the incidence of IVH in the babies, and antibiotics for pre-prom. Perinatal interventions, delayed cord clamping has been shown to decrease the incidence of IVH mainly by increasing the circulating blood volume, preventing the anemia in the babies, and preventing the hypotension, because circulating blood volume will be good and the need for more and more inotropes, volume boluses, blood product transfusions and all will be less if we do the delayed cord clamping. So that should be done for at least 30 to 60 seconds in all babies. Umbilical cord milking should not be done in babies with less than 29 weeks of gestation to decrease the incidence of IVH. And at the time of delivery, prevent hypo or hyperthermia, and provide proper respiratory care with appropriate PIP and PEEP. Postnatal interventions, early surfactant and caffeine decrease the respiratory morbidity of the baby, thereby decreasing the incidence of IVH. Avoidance of fluctuating cerebral blood flow and treating PDA and major hemodynamic disturbances, coagulation abnormalities, thrombocytopenia. Preventing late onset sepsis and NEC help in a long way in decreasing the incidence of IVH. So during the time of newborn resuscitation, gentle handling of the baby, avoid Trendelenburg or head low position, head and elevation, sudden changes in the position of the baby, prevent hypoxemia as well as hypercarbia. If you are providing CPAP, give it adequate PEEP, avoid excessive PPV and rapid volume infusions. So once the IVH has been diagnosed, the main focus will be on the supportive care and frequent monitoring to monitor for the complications and maintenance of blood pressure and blood volume to avoid further increase in the tendency for the cerebral bleed. Adequate oxygenation and ventilation, avoid hypo as well as hypercarbia and metabolic acidosis, give fluid and nutritional support and maintain the hematocrit and correct thrombocytopenia, coagulopathy, and if the baby has any seizures, treatment of the seizures and serial monitoring. So diagnosis of post hemorrhagic ventricular dilatation, how we will do clinical signs will be there, as well as we'll monitor the head growth periodically and measurement of directly by the neurosonogram, measuring the lateral ventricular size and Doppler of the anterior and middle cerebral arteries to measure the RA. So first the clinical signs will be present may little late. So first we will measure, more reliable will be the ultrasound related measurement of the ventricular dilation. So among the clinical signs, bulging fontanelles, splayed sutures, lethargy, poor feeding and vomiting are seen if the babies have raised intracranial pressure along with hypertension and bradycardia. So the rate of normal head growth for the babies of 26 to 32 weeks is around 1 mm per day, and 32 to 40 weeks is 0.7 mm per day. Increase of head circumference more than 2 centimeters per week or more 2 centimeters or more than 14 mm per week is considered as a significant of this post hemorrhagic ventricular dilatation. More than 14 mm per week or 2 mm per day. And the rate and severity of the progression of ventricular dilatation is by ultrasonography and plotting the same in the Levin's chart. Doppler of the anterior cerebral artery or middle cerebral artery to measure the resistive index. A resistive index more than 0.85 suggests raised intracranial pressure. So the extent of ventricular dilatation is measured by the ventricular index, anterior horn width and thalamo-occipital diameter, which I'll show in the subsequent slides. The first sign of increase in the intracranial pressure is a change in the ventricular shape of the lateral ventricle with the rounding of the frontal horns and an increase in the anterior horn width. So moderate risk, when you categorize the baby with an IVH into a moderate risk, when the ventricular index is more than 97th percentile to less than plus 4 mm of the 97th percentile, and the anterior horn width distance is between 6 to 10 mm. Babies will be classified under high risk if the ventricular index is more than plus 4 mm of the 97th percentile. So that is known as the action line, where you have to do regular CSF tapping and if needed assisted devices like external ventricular device and ventriculoperitoneal shunt, and the anterior horn width should be more than 10 mm and the thalamo-occipital distance should be more than 25 mm. So these are the measurements. In the coronal plane you can see both the lateral ventricles, from the interhemispheric fissure in the midline to the most lateral part of the lateral ventricle is known as the ventricular index, and this is the anterior horn width, which is measured in a perpendicular direction to the ventricular axis. So this whole thing is the hemispheric width. In this is the sagittal view in which you will measure the thalamo-occipital distance. This is from the thalamus to the occiput. Will measure the ventricular distance. This should not be more than 25 mm. So progression of ventricular dilatation. So not all the ventricular dilatation will need treatment. Some of them undergo spontaneous arrest. That is around 40% of them regress spontaneously and remain either the same size or regress, and 50% of them persist slowly progressive ventricular dilatation will be there in 50% of the cases that can be managed with lumbar punctures, and rapidly progressive ventricular dilatations will be treated with the ventriculoperitoneal shunt. So if you see the IVH 100% of the cases, slowly progressive will be 25%, non-progressive will be 25%, and no dilatation will be 50%. So management, serial lumbar puncture should be done like whenever there is a ventricular dilatation more than plus 4 mm of the 97th centile. This is as a temporary measure to drain the CSF. How much to drain? Around 10 to 15 ml per kg of the CSF should be drained each time before the baby can be put on any temporary ventricular drainage or ventriculoperitoneal shunt. Temporary ventricular drainage is done by direct external ventricular drain or tunneled external ventricular drain or subcutaneous ventricular catheter to reservoir or subgaleal spaces. So the ventriculo-subgaleal shunt, the CSF will drain automatically, no need to tap every day, and followed by ventriculoperitoneal shunt or external third ventriculostomy as per the condition of the baby and the neurosurgeon's opinion. So this drainage, irrigation and fibrinolytic therapy has been tried in some babies to see if it reduces the incidence of neurosurgery in the with IVH in these preterm babies, but it was found to be of minimal benefit. In this bilaterally invasive devices should be placed and fibrinolytic therapy is done into the CSF. But that is not very much useful for the decreasing the further progression to the surgery. So therapeutic LP is done whenever the head circumference increases more than 14 mm per week or more than 2 mm per day. It can be done for up to 2 weeks. Whenever there is a ventriculomegaly or the Levin's index is greater than the action line, which is 97 centile plus 4 mm. From the falx to the lateral wall of the body of the lateral ventricle, and with features of signs of raised ICP like bulging fontanelles, splayed sutures, or neurological signs like lethargy, poor feeding, tone abnormalities, or seizures. And resistive index also can be calculated on Doppler with a RA of more than 0.85. 10 to 15 ml per kg of CSF should be drained, rate not more than 1 ml per kg per minute. And the diuretics like acetazolamide and furosemide are not routinely indicated because they lead to the electrolyte disturbances. So that is about the IVH, germinal matrix related IVH and the prevention of the same and the monitoring and treat management options in preterm babies. Now let us go to the how to monitor, how to do the neonatal cranial ultrasound. So the neonatal cranial ultrasound is very advantageous in the sense that it is a non-invasive procedure and painless procedure, and it is easy to learn and it is baby friendly. Also portable, it can be done bedside for the baby and it is radiation free and no sedation is required, and there are relatively no contraindications to do the bedside cranial ultrasound. It is easy to learn and can be even done by neonatologists also with simple learning techniques. Now, why do we do the cranial ultrasound? There are multiple indications, generally to look for the normal cranial anatomy and for the diagnosis of the IVH or PVL or structural anomalies or any ischemic changes or intracranial calcifications, to monitor the brain growth and brain maturation, and it is also a prognostic indicator whenever there is a bilateral grade 4 of IVH in a very preterm baby, 26-25 weeker. So then for withdrawal of care and prognostic, explaining the prognosis to the parents as a prognostic indicator also, this cranial ultrasound will help, and to monitor for the complications, post hemorrhagic hydrocephalus, and for interventions, ventricular tap, ultrasound guided interventions, as well as measuring the cerebral blood flow. So what is the timing for routine ultrasound in the preterm babies? In a baby who is born less than 29 weeks, first initial scan should be done on day 1, followed by day 3, and then day 7 and 14, 28. And one more neurosonogram is done before discharge, that is either at 36 weeks and then followed by term equivalent scan at 40 to 42 weeks of gestation. For a baby who is born at more than 29 weeks, the propensity for the IVH gradually decreases. So the first scan can be done within 48 to 72 hours, followed by another scan at 7 to 10 days, and then directly we can do at 28 days. And before discharge or 36 weeks, whichever is relevant at that point of time. And a term scan is done for all babies who get discharged from the hospital in follow-up. So Coming to the indications, antenatally, if there was like any history of in utero transfusion or twin to twin transfusion, whether there was any dysmorphic baby, congenital or perinatal infections where you want to look for intracranial calcifications, lenticulostriate vasculopathy, ventriculomegaly, these conditions can be indications for the doing the neurosonogram. In IUGR babies and antenatally any CNS abnormality has been diagnosed, then we can confirm it once the baby is born with the postnatal neurosonogram. Postnatally, the indications being prematurity, any baby born less than 32 weeks and less than 1500 grams definitely should get a neonatal ultrasound once, and also before discharge and further at term gestation. In addition to this, other conditions like post-surgical or cardiac intervention, including PDA ligation, any baby who has undergone a significant procedure in the NICU, so it's better to get one neurosonogram for the baby, like a baby who has undergone PDA ligation, or the baby is in congestive cardiac failure needing multiple inotropes and blood products, baby is sicker on ventilatory support, post hemorrhagic ventricular dilatation, any abnormal head growth or shape or trauma at the time of birth beyond simple molding, and any subgaleal bleeds. Next, acute complications such as pneumothorax, hypotension, infection, NEC, meningitis, ventriculitis, abnormal neurological signs in the baby like hypotonia, abnormal posturing, abnormal movements, neonatal seizures, any baby with neonatal seizures also better to get one neurosonogram. Hypoxic ischemic encephalopathy, perinatal asphyxia, and hypoglycemic seizures, particularly the posterior occipital views are important for these babies. If nothing is visible on the neurosonogram, then better to get it confirmed by MRI also in the case of baby with hypoglycemic seizures or brain injury. Term floppy infant not feeding properly, we should do an early scan and repeat if symptoms are persisting. And any sick preterm neonate with an unexplained fall in hemoglobin, so we should definitely rule out the intraventricular hemorrhage, those baby, and the routine screening ultrasounds as we have mentioned before for all preterms. So what are all the prerequisites to do the cranial ultrasound? First of all, we need the ultrasound machine, and the probe will be the sector or curvilineal probe. We will see the 6 coronal images as well as 5 sagittal planes using a transducer with a high frequency of 7.5 to 10 megahertz for preterm, and a 5 megahertz transducer may be used for term or larger infants. And we should follow strict aseptic precautions with hand washing as per the steps of hand hygiene, and we should clean the probe and use the sterile transducer gel which is kept bedside for each and every baby. And with the neurosonogram, first we should have the normal anatomy and maturational changes which occur over the period of time, and age specific brain anomalies. We should have a prior idea before doing the neurosonogram. So anterior fontanelle is used as an acoustic window. It offers the view of the ventricles and the brain parenchyma. So 6 coronal images. These are, first one will be the anterior horns of frontal horns of lateral ventricles through the frontal cortex, and through the frontal horns of lateral ventricles at the level of the sylvian fissure. The third one is through the foramen of Monro. Fourth one through the third ventricle and thalamus. Fifth, posterior horns and choroids. And the last one is posterior to the choroids. You will see the occipital lobes. The ventricular index should be measured at the level of the third ventricle. So sagittal images, marker facing the baby's midface. We should mark right and left so that we don't give the wrong side of having the bleed. And midline view, and then the 2 lateral views on each side. In the midline, the third ventricle, cavum septum pellucidum and corpus callosum will be seen, and each lateral ventricle showing the frontal and occipital horns, and the brain parenchyma in each hemisphere outside the ventricle. So these are the images which will be seen in the sagittal plane. So in addition, these 2 main views, there are some other supplemental views, which is the posterior fontanelle view. in which the occipital horns of the lateral ventricles as well as the occipital white matter, so any cerebellar hemorrhage or posterior fossa malformations can be seen through the posterior fontanel view. Temporal view is 1 centimeter above and anterior to the external auditory meters. Here we can do the Doppler of the circle of Willis, and we can see the brain stem, midbrain, as well as any cerebellar hemorrhages, and mastoid view for viewing the posterior fossa and the midbrain. So neurosonogram can also be done to do the anterior cerebral artery Doppler. So these are the standard views. So coronal sections and sagittal sections. Midline view and lateral through the lateral ventricle and the peripheral cerebral hemisphere view. So coming to the coronal views, this is the first view through the frontal planes. Here you can see the orbits, and this is the frontal lobe, and this is the skull. So which is hyper intense and whitish in appearance. This is the skull of the baby. This is the midline, showing the frontal lobes as well as orbits. The frontal lobe is mentioned as F. Anterior to this skull bone, this is the orbits. So this is the second view through the frontal horns of lateral ventricles, showing the corpus callosum. This is a two tram track like two line appearance. This is the corpus callosum. This is the midline, intrahemispheric fissure, and the round thing, the star, which is marked with the star, is the cavum septum pellucidum. These are the frontal horns marked as F. The cavum septum pellucidum is a structure which is seen in the preterm babies. As the baby becomes more mature, it gets absorbed and will be seen as a smaller structure and will not be seen in term and bigger babies. Then coming to the this is the P is the putamen, deep brain structures, basal ganglia structures, putamen, and globus pallidus, and this is the caudate on top. This is the temporal lobe. So the one here marked with a dotted line is the Sylvian fissure. So we will be going as we go posterior. At the level of cerebral peduncle, we can see the beginning of the choroid plexus. Choroid plexus is a bright area. It should not be confused as a bleed. It's beginning along the roof of the third ventricle as well as the floor of the lateral ventricles. This is known as the 3-dot sign. Here you can see in these three areas, 3-dot sign. This one is the thalamus. And these are the cerebellar hemispheres, and posteriorly here you can see the hypoechoic area, that is the cisterna magna. So this is at the level of the quadrigeminal plate, which shows both the temporal lobes. These are the temporal lobes, thalamus, hippocampus, and this is the quadrigeminal plate. In the backside, you will be seeing the cerebellar hemisphere. And when you can you tell this, what is this one bright area? This is the choroid plexus. Bilaterally, the star marked one is the asterisk marked one is the choroid plexus, and behind that there will be the occipital lobes. So if you are seeing any bright area in the periventricular region, it should be of equal brightness or more bright than the choroid plexus to term it as a bleed. So this is at the level of the cerebral convex disc, which is showing the normal layers of the cortex, well-defined hyperechoic pia matter as well as the gray matter and the white matter. So the lightly hyperechoic is the white matter, whereas the hypoechoic gray matter, which you can see with the help of a straight arrow. So coming to the sagittal views, this is the midline view. Here you can see many structures. So let us go one by one. So in this is the same parallel line which we have seen in the coronal section. That is the corpus callosum. Below that, This asterisk which we have seen in that coronal view also, this is the cavum septum pellucidum. So this arrowhead is the cingulate gyrus, corpus callosum, cavum septum pellucidum, beginning of the choroid plexus. This choroid plexus is beginning like this near the caudothalamic groove, and it is going down. And this is a guitar-shaped structure. Here you can see a hyperintense area with the coming down of the choroid plexus. This guitar-shaped structure is the cerebellar vermis. So anterior to the vermis will be the midbrain and the pons. Posterior to the cerebellar vermis is the occipital lobe. So the third ventricle comes down and continues as the fourth ventricle downwards. So this is the parasagittal view where we can see the caudothalamic groove, which is a notch-like structure from where the germinal matrix arises. So this is the caudate nucleus, and this is the thalamus. So when the both join together, here there will be a notch-like structure, which is the caudothalamic groove. There the germinal matrix will be present. If you are seeing any bleed in that area, this notch will get obliterated. That is known as the grade 1 GMH. So I will show these structures when we go down to our NSU and do the NSG on the baby. And then this is the peripheral sagittal view through the sylvian sulcus, which is the dotted line. Here you can see the temporal lobe as well as the frontal lobe and the parietal lobe. So just here we will see the cerebral parenchyma, the presence of gyri and sulci, which will be obliterated in the case of cerebral edema, which is seen in perinatal asphyxia babies. So this is the mastoid view. Mastoid view is done just behind the ear lobule, and the probe is kept in a vertical fashion with the marker towards the vertex of the baby. Here you can see the cerebellar vermis as well as cerebellar hemispheres and the fourth ventricle pons and cisterna magna. This is the cerebellum, cerebellar vermis. And cerebellar hemispheres. This is the fourth ventricle, number 30, as well as this is the behind the cerebellar vermis is the cisterna magna. Pons is in front of the cerebellar vermis. So this is the temporal view using the temporal window, which is 1 centimeter above and anterior to the ear of the baby, external auditory meatus. Here through the temporal window, we will be seeing the midbrain, third ventricle as well as interpeduncular fossa, mesencephalon, and here we will be seeing the circle of Willis. So circle of Willis is the communication between the arteries and the veins in the brain. Here through the temporal view, we can see the circle of Willis, which if we have to put Doppler in that area, then we will be able to see the circle of Willis. So term versus preterm babies. In the preterm babies, all the ventricles are a little bigger, and you can see the cavum septum pellucidum, which is bigger. Whereas in the term babies, the ventricles are almost very small, slit-like, and the cavum septum pellucidum also regresses. And the number of like gyri, sulci, and pyometer and all the differentiation, gray-white differentiation also will be a bit obliterated in the preterm babies, whereas you can see this more clearly in the case of term babies. So this is the same, the caudothalamic groove where the germinal matrix hemorrhage occurs. So now let's see the grades of IVH. So grade 1 is the bleed which is related, which is confined to the subependymal germinal matrix. Here you can see the bleed in both the coronal as well as the sagittal planes, which is confined only to the germinal matrix. Here you don't see that notch-like thing anymore. So this is the grade 1 with no ventricular dilatation or ventricular extension. This is also the grade 1 bleed. This is the grade 2 IVH, in which you can see the bleed which is extending into the lateral ventricle, but there is no obvious ventricular dilatation. So this ventricular dilatation should be graded at the time of the bleed of the baby, because later on, so whenever the baby had a grade 2 of IVH, later on it may develop a post hemorrhagic hydrocephalus. Then that time we cannot say whether it was a grade 3 in the beginning. So whenever there was a bleed, that time itself we should differentiate whether there was any ventricular dilatation or not, and grade the baby accordingly. So this was the grade 2 IVH without any ventricular dilatation. This is the grade 3 IVH, in which we can clearly see that the lateral ventricles are grossly distended and there was a large bleed, which is more than 50% of the lateral ventricular size. This is the sagittal view. So this is the fan-shaped parenchymal extension of the bleed. Here you can see the bleed spreading into the parenchyma like this. This is the sagittal view of the same. This carries a high chances of mortality as well as long-term morbidity. So here some cystic PVL changes are also seen, along with the hydrocephalus is seen over here. So the first sign of hydrocephalus we discussed previously, it is the rounding of the margins of the lateral ventricles. Here we can see the dilated ventricles as well as the dilated temporal horn of the lateral ventricle. So coming briefly to the grades of periventricular leukomalacia, which is the D Vries classification. The grade 1 is areas of increased periventricular echogenicity without any cyst formation, which is persisting for more than 7 days. That is known as periventricular flare. If it persists for more than 7 days, it is known as grade 1 of PVL. Grade 2 is localized periventricular cysts, which are often located in the frontoparietal white matter. Grade 3 is extensive periventricular cysts, which are extending up to the occipital as well as the frontoparietal region. Grade 4, cystic lesions, if they are extending into the deep white matter also, then it is known as grade 4 with extensive subcortical cysts. So we'll see few images related to the PVL also. Here you can see the bilateral PV flare. And here as you see, there is the evolution of the cystic lesions in the frontal as well as parietal lobes. And then here in the sagittal plane, you can clearly see they are extending into the deep brain part also. So this is how to differentiate the PVL from the periventricular PVHI related cystic changes. So coming to some of the normal variations which are seen in the babies, it should not be diagnosed as like any hydrocephalus. So some of them are the conatal cyst and choroid plexus cyst. So the conatal cyst is usually seen lateral to the lateral ventricle with a septum which is seen adjacent to the lateral ventricle. So this is known as the frontal heart cyst or conatal cyst. It is a normal variant which does not have any neurodevelopmental sequelae or significance for the baby, just an incidental finding. This is the choroid plexus cyst, which is seen just at the initiation of the choroid plexus. Here you can see a small hypoechoic cystic-like lesion at the beginning of the choroid. This is the choroid plexus on both the sides. So this is known as the choroid plexus cyst. So this is the measurements which are generally given. Anterior horn width in a coronal view at the level of foramen of Monro, just anterior to the choroid plexus in the third ventricle. So the diagonal width of the anterior horn is measured at the widest point, and its measurement is given as in millimeters. So the ventricular index is the distance between the falx and the lateral wall of the anterior horn in the coronal plane. This we have already discussed. This is the thalamo-occipital distance in the oblique parasagittal view. The outermost part of the thalamus at its junction to the choroid plexus to the outermost part of the occipital horn posteriorly. So now coming to the grading of ventriculomegaly. If the size of the lateral ventricle is 0.5 to 1 centimeter, it is known as a mild grade 1. 1 to 1.5 centimeter is grade 2, and more than 1.5 centimeter size distension of the greater ventricle is lateral ventricle is grade 3. This is the Levin's chart where we plot the according to the gestation weeks of the baby and the ventricular dimension. Suppose if it is for a 32-weeker baby, if it is more than 15 mm, so then if it is 16 mm, it is 4 mm above the 97th centile, which is the action line. For a 32-weeker baby, it should be less than 12 mm, so it should be either 11 or 10, then that is normal. This is the 97th percentile, and 4 mm above it is the action line where we have to do the intervention. So coming to measuring the cerebral blood flow velocity, the quantification of the cerebral blood flow velocity is based on the calculation of resistive index or area under the velocity waveforms. The resistance index of Porsley is given by the formula where the peak systolic and the end diastolic amplitudes of flow are measured independently, and the ratio of resistive index is given by peak systole minus end diastole by systole again. So in resistive index, you can measure it as remember it as the denominator being the systole again, whereas pulsatility index is the difference peak systole minus end diastole by mean velocity we should take for pulsatility index. So this is the circle of Willis where the all the arteries like anterior choroidal artery, middle cerebral artery, and internal carotid artery, everything converge together and drain into the venous supply. So the failure of regression of the median prosencephalic vein of Markowski results in the formation of the vein of Galen malformation, which is seen as a high output cardiac failure and cranial bruit in preterm, in term as well as preterm babies. So in the midline sagittal view near the ACA anterior choroid artery, if we apply Doppler over here, we can measure the peak systolic velocity as well as the end diastolic velocity, and the difference if we calculate it in the formula, we will get the resistive index. Resistive index is low in babies with perinatal asphyxia, whereas high in babies with hydrocephalus, sepsis, PD, etc. So this is the NSG image of a baby with hypoxia. There is a loss of gray white matter differentiation, if you can see, and it is increased echogenicity is there with the slit-like ventricles. This is the general picture which is seen in babies with perinatal asphyxia due to cerebral edema. So coming to this baby is having this lenticulostriate vasculopathy, if you can see near the Sylvian fissure in the parasagittal view as well as in the coronal view, you can have this lines-like structures. This baby was a IUGR baby with hepatosplenomegaly, failure to gain weight, respiratory requirement. So as a baby diagnosed to have a congenital cytomegalovirus infection. You can also see the subependymal pseudocyst clearly visible in the sagittal view, and here also you can see some cystic-like lesions in the subependymal area. So subependymal pseudocyst and lenticulostriate vasculopathy is seen in babies with congenital CMV infection. In toxoplasmosis, what you look for? We look for ventriculomegaly and calcifications in the basal ganglia, thalami, and cerebral cortex, as well as periventricular white matter. So there are some malformations like Arnold-Chiari malformation, where there will be a herniation of the cerebellar tonsils, and as well as the Dandy-Walker syndrome, where the fourth ventricle will be enlarged and it will be communicating with the cisterna magna. So with hugely dilated lateral ventricles. So these are some of the things which can be diagnosed by neonatal cranial ultrasound, mainly useful for the preterm babies and in term babies or any sick baby in NICU, where you can diagnose some specific conditions, provided you have prior knowledge of the anatomy and age-related maturational changes which are seen, and you should also correlate them with the clinical signs and then diagnose appropriately. So this is the last slide. So here what we should do to take care of the machine, we should keep the machine properly, clean the buttons, remove any dirt, spill, gel before commencing the scan. So first, before applying the probe to the baby, we should Clean the probe perfectly so that you do not spread infections in between the babies. With clean perfectly with alcohol wipe, and ensure all the cords are clear of the wheels. And when you are scanning, to avoid the machine from moving here and there, lock the wheels. And use it gently, and please ensure that you clean the probes after each and every use, and place it in its usual position after finishing the scan, so that it will be easy for the others to again access the machine and find it whenever it is needed. Of course, the regular hand hygiene and precautions, and cleaning the baby after the scan, cleaning the jelly also are all very important to prevent the spread of infections for these newborn babies. So this is about the preterm intraventricular hemorrhage as well as the neonatal cranial ultrasound for the babies. Now we will go to our NICU and try to do these coronal as well as sagittal images on our preterm babies. And we also have a case of Dandy Walker syndrome, in which you can see the hugely dilated lateral ventricles. That baby is now having an external ventricular device, and we are regularly tapping and due for ventricular peritoneal shunt. Thank you for patient listening.
Audio.
So here we have a 36-day-old, 26-weeker, one of the twin male baby. Baby is currently in room air and maintaining saturations. Baby is comfortable. There are no retractions. We will see first before doing the neurosonogram for this baby. We have to switch on the machine, and then we should keep clean the probe. First, we should clean the probe from the starting part, and then we should clean the probe entirely with a sterile gauze and an alcohol wipe. And so we have cleaned it till the maximum distance like this. And then when we are before starting the examination, we have to go to the exam mode. And then here you will see the three views. First one is the cardiac view, second one is the neonatal view, third one is the abdomen view. So we have to select the neo view. So we are selecting that, and then we should apply the jelly. We should keep a sterile jelly on the bedside of the baby underneath the warmer itself, so that it is warm and we don't apply the cold jelly to the baby. So now we are applying some jelly to the baby. We just apply it with the balls. So we have to commence the neurological neurosonogram only when the baby is comfortable and fed properly, and it is to ensure that the baby is not agitated or crying. So we will see the first through the anterior fontanelle, we will see the coronal as well as the sagittal views. So in the coronal view, we have to just apply this probe on the AF with the marker towards the right side. So then you can see anteriorly, I'll just show you. So the bright hyperechogenic is the skull bone, and anterior to that you can see some hypoechoic two dots are there, which are the orbits. So now you can see clearly. This is the bony part, and these are the two orbits. This is the skull bone, and this is the anterior frontal bones, which we have seen in our presentation. Now we have to slightly tilt the probe going a little backwards. Then you can see these are the two lateral ventricles. This baby is a 35-day-old now. So in between you can see this is the cavum septum pellucidum. As the baby matures even more, the cavum will become small and eventually it will disappear. So I will just freeze it over here for a while and then show you. This is these two parallel lines which you can see is the corpus callosum, and this is the intrahemispheric fissure or FARCS. These are the two lateral ventricles, cavum septum pellucidum. Okay, now you can see clearly. Okay, lateral ventricles, cavum, and these are the basal ganglia. Caudate nucleus and thalamus will be down. Putamen and globus pallidus will be seen. So we will unfreeze again. And as we are going posteriorly, so you will be seeing some bright structure which is arising. So what is that one? This is the choroid plexus. It will be arising from the, so the three dot sign actually we cannot make out now, but the choroid plexus is now clearly seen. So this is the bright structure which arises from the caudothalamic group. And if you go even further posterior, you will be able to see the So posterior to the choroidal plexus, we'll be seeing the occipital blush. So you can see some bright area. This is known as the occipital blush. So if you are seeing any bleed, you will be seeing here in the lateral ventricles. So if you see any bleed, you should be confirming it with both the coronal as well as the sagittal plane. I hope till here you understood it. Now let's go to the sagittal views. Sagittal view, midline sagittal view, and two lateral views. So this is the midline view. Here, so the this is the midline view. You can see the lateral ventricle. And if you turn tilt it to slightly angularly, you will be seeing the notch which in the caudothalamic below. So I'll just freeze it. So a notch-like structure is seen between the caudate and the thalamus. This is the caudothalamic view. If you see any bleed over there, that notch will be obliterated and you will be seeing a hyperechogenic area. So here you can see now clearly, the notch is clearly seen. And if you tilt the probe even further, you will be seeing the, so I'll freeze now again. So this is the origin of the choroid plexus and this is the guitar sign. So if you imagine a body of the guitar and the handle of it, this will be the cerebellar vermis and the third ventricle will be extending down, going down to the fourth ventricle. Posterior to the cerebellum, you will be seeing the occipital lobe. Anteriorly, you will be seeing the pons and the medulla. Okay, so meanwhile, you have to be monitoring the vitals of the baby also. Make sure that the baby is calm and not agitated. So, in the sagittal view, we will try to look for the Doppler. So, I will just try to put color over here. So, you can see the ACA clearly. Now, we will put the Doppler over there. I will put the Doppler again. So, here you can see clearly the systole and the diastole. So, peak systolic velocity we will calculate. This is the peak systolic velocity. Select and then one more end diastolic velocity we have to calculate. So this is the end diastolic velocity. Okay, so now according to the formula, if you calculate the peak systolic minus end diastolic by systolic, it will become the resistive index. Similarly for the so if the resistive index is more, what are the conditions causing increased resistive index and what are the conditions causing decreased resistive index, similarly for the pulsatility index, systole minus diastole by mean. So this is the Doppler over the ACA and the method to calculate the RA. So now let's try to see, like we can see through the temporal lobe. So I'm just trying to put the probe just anterior to the ear. Here you can see one window. So if you put the probe over here, you can see parts of the midbrain. So again, we have to apply the color over here. So if seen properly, we can be able to see the circle of Willis over here. Baby is a bit agitated. This is a midbrain and so you can be able to see the circle of Willis. So you can see some arterial and venous flows over here. So that will be the circle of Willis near the midbrain. So here you can see. So if you are finding some vein of Galen or something, we can see through this temporal view. So the next is the just two additional views. That is the posterior fossa view, and posterior fossa is through the posterior fossa. You can see the posterior part of the brain, and you can look for cerebellar and hindbrain, any bleeds. Suppose hypoglycemic brain injury, you can see the occipital lobe and find any bleeds over here in this area. So this is clear. And then the other one is the mastoid view, which is just behind the ear, and the probe should be perpendicular, pointing towards the vertex. So here also we'll be seeing the cerebellum, and any cerebellar hemorrhages will be seen through this mastoid view. Thank you.
Oh, this was the baby I was saying about the hugely dilated lateral ventricles and increased head size. This baby is having typical features of raised ICT, like whenever there is hypertension, baby will have symptoms of decreased feeding, dull activity, and vomiting. So you can see the lateral ventricles, where all ventricles are hugely dilated, and we have done the CT scan for this baby. This is showing the um, dilated fourth ventricle. And, so this baby is having an Omaha reservoir external ventricular device, and we are regularly tapping the CSF for this baby, and plan to go for the ventricular peritoneal shunt once the infection, that is the protein level, comes down. So this is the coronal view in which you can see the usually dilated ventricles. I'm going a little posteriorly. Less of brain parenchyma and only the dilated ventricles we can see. Okay, we are ending our discussion here. Thank you.